Okay, so I'm going to talk to you today about we're hopefully our PhD student will be just pre-printing these results as we speak. About basically the early findings from a study that we did funded by Dysautonomia International some time ago, but there were lots of hiccups along the way in terms of looking at brain fog in postural tachycardia syndrome. Using a experimental medicine challenge. So obviously one of the things we wanted to do was acquire brain images, particularly perfusion images, under orthostatic stress. And we certainly don't have the capacity in the UK to get anyone from lying to standing in an MRI machine. So we had to get a custom-made lower body negative pressure chamber, which some Italian engineers made for us out of neoprene. And the reason why we wanted to do this was, probably back in 2017 now, a group in Cardiff, which is in Wales, which is another part of the United Kingdom, they made their own lower body negative pressure chamber out of wood and saran wrap, and they showed that in healthy controls, a lower body negative pressure chamber, lower body negative pressure minus 40 millimeters of mercury induced changes in cerebral blood flow and perfusion in the otherwise healthy brain. And so we hypothesized that patients with POTS may be particularly vulnerable to orthostatic challenge. Now this presentation is really the behavioral results. The brain imaging analysis is currently underway. So for those of you who don't know me, and you're probably wondering what is a psychiatrist doing in the postural tachycardia space, I do not believe that postural tachycardia is a psychiatric or a psychosomatic condition. My business, I'm something called a liaison psychiatrist, so I think you call them consultation liaison psychiatrists, is basically trying to medically explain what people consider medically unexplained symptoms, which is an unusual position for a liaison psychiatrist. But I started off in hypermobility working with Hugo Critchley, who Professor Matthias used to work with. And basically hypermobility has led me down many very interesting research avenues. But one of the things that, of course, if you get into hypermobility, you're going to find out about is postural tachycardia syndrome. So I work as a psychiatrist in our neurodevelopmental service. So that's adults, autism, ADHD, and Tourette syndrome, and where we have the world's first neurodivergent brain body clinic. And you might be thinking, what's that all about? But all of our patients, almost all of them, are hypermobile, and most of them have chronic pain and fatigue, and some of them have very weird autoimmune conditions. It's basically a hotbed of medical rareness, but actually happening to us very commonly because all of the patients have a neurodevelopmental condition. So I stole this big idea from Professor Edward Bullmore, who is a professor of immunopsychiatry in Cambridge. We should drop the distinction between mental and physical health. The current false dichotomy holds back research, stigmatizes patients, and I think it holds back clinical practice. And we know, I was just at the EDS Society meeting in Toronto, and Colin Halverson presented. He did that groundbreaking paper, qualitative work, showing about, EDS patients, the delays to diagnosis, the gaslighting, the traumatization, and we know that's true with POTS patients too. So I did my PhD back in 2012 to 2016 in hypermobility, and right then this is what we knew about hypermobility affecting all sorts of things. I'm sure you can't be working in POTS without it having cropped up. But hypermobility is far more than just having flexible joints. It's an underlying difference in connective tissue. And actually, despite what the EDS Society would say, this is actually relatively common. It can be highly advantageous. So people like Simone Biles and Michael Phelps, they're hypermobile and they've got ADHD. And it's linked to loads of medical issues. And these issues cross systems and involve both the body and the brain. And I think one of the biggest problems for hypermobility research and clinical practice is what I call the alphabet soup, which I'm going to show you a slide, but all of the different terms to describe it are a nightmare, even if you have a PhD in hypermobility. So trying to explain it to other doctors and to the general public is quite fraught. We know that that this can impact the autonomic nervous system. I'm a patron of a charity called SEDS Connective in the UK. They are international, but this is just a soup of hypermobility related terms, and they keep changing, and we know that the terms are going to change again in 2026. And I still see patients, I mean, often, most of them, there are no good pathways for hypermobility in the UK. Often lots of people don't have a diagnosis, but I still hear of people being diagnosed with EDS3. It's all a mess. So for those of you that are interested, there were 2 parallel classification criteria. One that started off with hypermobility syndrome, which became benign joint hypermobility syndrome, which has been supposedly superseded by hypermobility spectrum disorder. We had EDS3, which became EDS-HT, which became HEDS. They're basically just terms, and I think they are quite arbitrary for symptomatic hypermobility. So all of the Ehlers-Danlos syndromes feature hypermobility, but not all hypermobile people will meet diagnostic criteria for the Ehlers-Danlos syndromes. And all of the Ehlers-Danlos syndromes, apart from hypermobile EDS, have defined monogenetic causes. So I'm sure you already know, but there are ways to assess for hypermobility. So you can do a physical examination like the Brighton scale, or Brighton, I think, very technically, if you're going to say it right. But that misses important joints like ankles, hips, and shoulders at sublux, and I think is biased against men. I mean, this is a slightly controversial subject, but I think there are actually more symptomatically hypermobile men out there than we think. So what we've actually found really useful is the 5-part questionnaire for detecting generalized joint hypermobility. So generalized joint hypermobility is just the presence of hypermobility. It isn't necessarily symptomatic, but you can screen for it using a really straightforward 5-part questionnaire. Can you now or could you ever bend your hands flat on the floor, put your hands flat on the floor without bending your knees? Can you now or could you ever touch your thumb back to touch your forearm? As a child, did you amuse? Now you have to be careful, you didn't actually have to amuse people. As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double jointed? So 2 or more, it's very likely that you have generalized joint hypermobility. Now, this is how you look for hypermobile EDS, and you can only go in there with a quite high Brighton score. And then there are a number of what we might consider connective tissue features. So these are things like soft, hyperextensible skin with striae, so stretch marks, these pyogenic papules, hernias, prolapses, funny scarring, dental crowding, arachnodactyly, and then a positive family history, which is actually really hard to get because most people haven't been evaluated, and then widespread pain or joint instability, and a further criterion that you shouldn't have one of the other forms of EDS. So we know that hypermobility affects people in all sorts of ways, and I got into it, as I explained, through anxiety. There was a Spanish group that showed that if you took 100 people with panic attacks, 70% of them had generalized joint hypermobility compared to less than 20% in the general population. And just as I was starting my clinical academic career, there was a real there was a sudden interest in whether there was actually a shared gene. This Spanish group said they'd found one on the long arm of chromosome 15 that was never replicated. But what we knew as I started in the hypermobility field was that hypermobility actually is everywhere in musculoskeletal medicine and rheumatology, but very, very rarely recognized. And at that point in 2008, only 1 in 19 times. But you can see that they were already thinking about the dysautonomias, and that was sort of on the cards at that point. Why won't the slides go forward? Now we know that hypermobility in EDS is associated with all sorts of things, including GI disorders, chronic fatigue, postural orthostatic tachycardia syndrome, orthostatic hypertension, and orthostatic intolerance. When I give talks, I mean, we all know POTS is not, there is a syndrome, there isn't a single cause, but we know that people with symptomatic hypermobility, maybe about 80% of them have some form of orthostatic intolerance. And the problem is, in the POTS population, is you're going to get different numbers of hypermobility according to how you classify it. So if you're going for a strict HEDS diagnosis, you're probably not going to say that all of the patients have it. But if you're going for generalized joint hypermobility, they probably all do. Well, not all, but most of them. So there's, over the years, we've learned loads of things about hypermobility, and particularly about immune dysregulation, which might tie in with small fiber neuropathy and things like that. We've done some work where we showed that if you took patients with chronic pain and fatigue, that they, about 80% of them meet the old Brighton criteria for joint hypermobility syndrome. I presented here at this group our paper that was ultimately published in BMJ Public Health, where we shows that generalized joint hypermobility associated with not recovering from COVID. And we know that there is massive interest in POTS as part of the post-COVID phenomenon. We also, I mean, what we're probably known our group for now is this paper, and Chris Mathias is one of the authors here, where we showed that in a group of people with ADHD, autism, and Tourette syndrome, that they were 4 times more likely to be hypermobile, and they had physical symptoms, including symptoms suggestive of dysautonomia and pain, and that hypermobility was the link between having a neurodevelopmental condition and having these physical health symptoms. We published last year showing that neurodivergent people, this isn't people in the general population, ADHD and autistic traits predict emotional regulation difficulties because of a sense of uncertainty about where you are in space. We initially published structural brain imaging showing differences in amygdala in hypermobility. And I did my PhD in how do you get from having flexible joints to having a panic attack. I do not think that postural tachycardia syndrome is anxiety, but I think that if you experience these changes in the body due to your autonomic nervous system, you may wonder what is going on, and you may attribute that to anxiety. And when you and basically you've got this, we talk about this thing called Bayesian prediction errors. I don't know if you're familiar with them, but the idea is the brain is a prediction machine. So we are constantly, if we took in all of the internal and external information that we needed at any one time, our brains would just sort of blow up. So we shortcut it by making predictions. And sometimes those predictions don't reflect what's actually happening, and that causes a sort of jolt, a physical shudder to the brain, which may manifest as anxiety. And one of the things is if you suddenly feel weird, but you don't realize it's because you stood up, or you're dehydrated, or you've had a hot bath, or you've had a large meal, this uncertainty could be mistaken or feel like anxiety. So we showed in 6,000 14-year-olds that if you had generalized joint hypermobility at 14, you were more likely to have diagnosis of anxiety and depression at 18, and that this was related in boys to a mediating effect of high heart rate. We just published, I think it was this year, functional imaging of hypermobility and anxiety, again showing interesting areas like amygdala and the insula, and a lack of executive control in the frontal cortex. And interestingly, a similar pattern is actually seen in ADHD. So we think there's abnormal frontolimbic reactivity. Now, this is probably more interesting for people interested in POTS. So what I was talking about, this kind of what the brain is expecting and what it's not, we present autonomic perceptual mismatch as a measure. So we took people's, we did an active stand test. We worked out the change in heart rate from lying to standing. And we also took a symptom inventory, and we basically worked out the deviation between what was happening and the symptoms. And we correlated this with brain activity. And as you can see, that the orthostatic intolerance heart rate change was much higher in the hypermobile anxious group compared to the non-hypermobile group. But if you were non-hypermobile and anxious, there was barely any change. So it was really this intersection of hypermobility and anxiety that was leading to high heart rate. And then you can see the same interaction with orthostatic intolerance symptoms. If we correlate, we can correlate anxiety score with that mismatch, and you can see there's an interaction. So there's a correlation in patients, but not in controls. And this is, you can see here, the hypermobile anxious patients, really high autonomic perceptual mismatch. And we show this in brain. So in the brain, autonomic perceptual mismatch correlated with an enhanced activation in emotion processing and autonomic control regions, notably anterior cingulate. Anxious individuals exhibited increased mid-insular cortex activity. Activity was decreased within the frontal lobe, region implicated in cognitive control. And symptoms of orthostatic intolerance mediated the link between hypermobility and anxiety. Together, these findings support a neural basis of autonomic perceptual mismatch. This is supported by the engagement of neural systems for emotion, cognition, and interoception. This work highlights convergent aspects of neurodiversity, mental health, connective tissue disorders, and brain-body interactions relevant to precision healthcare. So that's a big thank you to all of the people who were involved in making that study happen. We used the data from that study to have a trial of a interoceptive training therapy designed to minimize that autonomic perceptual mismatch, and we called that ADAPT. And we now have a large grant from the Medical Research Council to see if it's feasible to put that interoceptive training into our primary care talking therapies. It's not a talking therapy, but into, you know, the first line of non-drug treatments for anxiety. So we published on, we've linked hypermobility to pretty much every possible neuropsychiatric thing. And we've shown that variant connective tissue and symptoms of dysautonomia are associated with multimorbidity at the intersection between physical and psychological health. We've written about pain and fatigue, and I mentioned that previous study, and the interest in long COVID. We also showed that if you, this was in 8,000 birth cohort of about 8,000 children, that if you had ADHD and autistic characteristics at 7, you were more likely to have chronic disabling fatigue at 18, and that was mediated by high levels of IL-6 age 9. We just published, I think the week before last, a follow-up to our long COVID study. So we replicate our original long COVID study demonstrating the role of generalized joint hypermobility. Was in a very white female group. I think 90-something% white, 90-something% female. So we got some money from the Ehlers-Danlos Society, and I think the now defunct EDS Foundation, and we used an American thing called Dynata to find us participants, and we found exactly the same thing. So 30% more likely to develop long COVID after a COVID infection if generalized joint hypermobility. But we also characterize some additional hypermobility features. And if you were in the top decile, we called it extreme hypermobility, and the risk of long COVID with extreme hypermobility, the odds ratio was 2.12. So you were twice as likely to develop long COVID. Okay, we also, now this is quite interesting data from our mechanisms of chronic pain and fatigue study, and I presented this at the Ehlers-Danlos Society meeting 2 weeks ago. I think I'm jet lagged though from it, so I can't remember how long ago it was. We had a number of patients and we gave them an inflammatory challenge. This is typhoid vaccination. I may have talked to you about this before. And we found that in the pain and fatigue patients, there were interesting upregulations in gene expression that seemed to be associated with mitochondrial metabolic processes. And now convergent with data that I think just came out the Norris lab a couple of weeks ago, we found that at baseline, if you put the transcriptomic gene expression profiles into a disease ontology database, so you say, what other conditions does this gene expression look like? Looks like an autoimmune condition, so it looks like lupus, dermatitis, eczema, and AIDS. And then really interestingly, if you throw in the inflammatory challenge, and long COVID is a bit like a natural inflammatory challenge, or COVID is a natural inflammatory challenge, but if you throw in the typhoid vaccination, and we look to see what does an inflammatory challenge in hypermobile people, this is generalized joint hypermobility, what does that, what diseases does that look like, that gene expression? I mean, I think this is fascinating stuff. Oh, we showed that this, there was an upregulation of pathways involved in inflammation. It looks like substance misuse, it looks like bipolar, autism, ADHD, hip problems and heart problems. So a really kind of interesting gene environment two-factor model whereby a potentially connective tissue is possibly associated with autoimmune processes, which then with other intersecting factors lead to neuropsychiatric and other features. So this is the study I want to talk to you about. It was funded by Dysautonomia International. And as I explained, we wanted to look to see if we could correlate, if we could see what happens in brain perfusion with lower body negative pressure, particularly interested in the phenomenon of brain fog. Now, Peter Rowe, who's on the call, is a collaborator on this grant. That studies had suggested that brain fog is actually one of the most impactful symptoms on POTS patients, and I don't know if it's just kind of in the UK, but there's a huge interest in brain fog these days because of long COVID, because of the menopause, and because of ADHD. So brain fog is on everyone's mind. We did a case control study. Now, interestingly, our primary inclusion criteria was a existing diagnosis of postural tachycardia syndrome, which is actually very hard to get in the UK. It's not easy, and it's a bit of a postcode lottery. So we had to make sure that our people who didn't have POTS didn't have POTS. So as part of the workup, we did a active stand, and if that active stand was positive, they were excluded from the control group, and medical advice was given about onward referrals. But we really didn't want our controls to actually have autonomic dysfunction. So there was an active characterization of that. We also obviously interest in hypermobility. We recorded whether they had any hypermobility diagnoses, but we also put them through a hypermobility assessment, which included the Brighton scale, the Brighton criteria, and the 2017 HEDS and HSD criteria. So this is the paper. It's being pre-printed right at the moment by Amy Carter, a PhD student, and the highlights basically is that this is one of the first papers to actually combine an autonomic challenge, the experience of brain fog, and hypermobility classification. We use lower body negative pressure. We basically show that brain fog is worsened by orthostatic stress, which is really interesting because it suggests that you can, well, I mean, it's kind of intuitive, but it suggests that we, in a subgroup of people, and I'm going to explain who these are, but the people with the significant connective tissue features, then probably measures to try and boost blood flow back to the brain will help with brain fog. And also we didn't find that the orthostatic challenge induced anxiety in patients, which was good. Well, not good, but you know, it's all part of the picture. So we know that POTS patients often have joint hypermobility, but we also know that this is very confusing. Is this GJH? Is this HSD? Is this HEDS? And we don't actually have good prevalence data for HSD or HEDS. We do for generalized joint hypermobility. But very few studies have systematically characterized hypermobility. So we thought that a better understanding of hypermobility in POTS is essential for recognizing unmet needs and improving clinical care. So we all know there's lots and lots of POTS is a syndrome. Several studies suggest a conceivable mechanistic link between hypermobility and POTS due to connective tissue laxity affecting vascular compliance, resulting in increased pooling and exaggerated tachycardia. Maybe to do with collagen and extracellular matrix related abnormalities. Therefore, studying brain fog in people with POTS is imperative, as they may be both related to autonomic nervous system dysregulation that may exacerbate brain fog. We hypothesize that the number of connective tissue features may be important for assessing orthostatic intolerance in hypermobile individuals and may predispose to brain fog. So we got our patients with a POTS diagnosis and those without a POTS diagnosis who definitely weren't screening positive for POTS, and they all underwent a detailed hypermobility assessment, and they went into the brain scanner, and in the brain scanner they underwent an ASL, which is arterial spin labeling sequence, and a bold sequence. Actually, in the bold sequence, I'm not going to dwell on it, it'll be really interesting when it's analysed. They had both true and false physiological feedback applied. And we quantified brain fog in a very basic way using a visual analog scale button press in the scanner. So I'm not sure, you might not be able to see. We were inundated with participants, even though I've said it's almost impossible to get a POTS diagnosis easily, especially in Sussex. We actually, overnight, via social media and various other things, we had 120 people try and take part, and we ended up with 27 in each group. And as you can see, we tried to age and sex match them. They were similar age. However, there was a slight difference in ethnicity. Sussex is a predominantly white place, so that we were not particularly targeting any groups for the control participants, though we are in a university and we did some students will have taken part. So this is the hypermobility data. So these are HSD features. So you can see that our POTS patients, 85% had had joint instability, 96% had had persistent joint pain, 80% had had soft tissue rheumatism. They almost all had a Brighton score of more than 1. And you can see that that was the same for the controls, and that half of the controls met HSD criteria. So half of the controls had HSD, and it says half of the controls have HSD in the POTS group, but actually the other half have HEDS, which is the interesting thing. So so basically, both the POTS group and the controls group, there's an awful lot of generalized joint hypermobility, and there is a degree of symptomatic hypermobility, which is actually quite common if you look for it. But what we find is that half of the POTS group, compared to only 20% of the controls, have the requisite number of connective tissue features in criterion 2A. There's no family history of HEDS in the control group, and very few in the control group have joint instability or dislocations, and a considerably higher median number of connective tissue features. And as you can see, in the POTS group, 96% had either EDS or HSD. There's slight confusion because one patient actually had a diagnosis of classical EDS, so they're excluded from the HEDS diagnostic met. But so the controls didn't tend to have HEDS, they tended to have HSD. So what we find, and this is just our brain fog induction, that the this is before challenge and after challenge, and this is this is the residuals, there's a significant two-way interaction of being a POTS patient on orthostatic and having an orthostatic challenge on brain fog induction. So you can see those slopes are slightly different, but they're not. But the p-value is pretty weak. It's 0.042, and that is not a beautiful graph. I'm going to show you some beautiful graphs in a sec. So it gets a little bit more interesting when we look at the whole group and we work out whether they have HEDS or not. And you can see that those slopes are beginning to differentiate. But furthermore, there is a main effect, so really striking, if you have HSD or HEDS, look at that induction of brain fog compared to not having any symptomatic hypermobility. And then if we look in the POTS patients alone, who all had the same degree of brain fog on average before the lower body negative pressure, that there is differentially increased brain fog in the POTS group when there is HEDS rather than HSD. So in POTS patients specifically, a significant two-way interaction, so difference of the differences of having hypermobile EDS on the orthostatic challenge when accounting for age and sex, i.e. the patients with HEDS compared to HSD had a greater induction of brain fog as a result of the challenge. So as I said, we didn't find any induction of anxiety. In fact, our controls had slightly higher anxiety measurements, but again, anxiety measurements you can kind of pick and choose. Some of them are very autonomic, the anxiety features, some of them are less so. But the change in state anxiety did not correlate with change in brain fog. And then interestingly, this is just at baseline. We have submitted this paper for review, and it was well, we got some inconsistent reviews, but one of the things was there was a bit of confusion about what exactly is dissociation compared to what is brain fog. And we found that if you were a POTS patient compared to a control, you had greater dissociation symptoms, so kind of feeling disconnected from your brain and body, and that was mediated by the number of orthostatic intolerance symptoms, and that if you were a POTS patient compared to a control, you had obviously, hopefully, significantly higher orthostatic intolerance, and that the relationship between being a POTS patient and having orthostatic intolerance symptoms was mediated by the number of connective tissue features. So it seems that it's not just a question of whether you are hypermobile, but the number of the degree of body involvement is really important. So brain fog is an overlooked symptom in postural tachycardia syndrome, but is a considerable source of impairment in many clinical contexts. Our study found that an orthostatic challenge induced brain fog in POTS patients compared to controls. Furthermore, the degree of connective tissue involvement, i.e. meeting diagnostic criteria for HEDS rather than HSD alone, was associated with a greater induction of brain fog after orthostatic challenge in POTS patients, and the frequency of HEDS, 44%, and generalized joint hypermobility, 90%, in POTS patients was higher than some reported previous estimates. But the previous estimates had not systematically looked for it, I don't think. But I think what it suggests, and this is a bit like hypermobility and long COVID, is that there is a subgroup of POTS patients, and they may be the ones that have the volume distribution problems, and that is, you know, particularly amenable to electrolyte boosting and compression. So we are just, we've had a number of technical problems along the way. It's taken a number of years for this study to be finished, but it is completely finished. And our PhD student will be has pre-processed the brain images, and we will be putting them through an agreed arterial spin labeling pipeline in the next couple of weeks. So a huge number of thank yous to people who have taken part in the who have you know, researchers who have helped along the way, but particularly Kevin Davis and Hugo Critchley. And that's Hugo and I in Rome for the EDS scientific meeting at the previous scientific meeting. And where are we? And yes, and a big thank you to Amanda Marshall, Amy Carter, and Joel Patchett, who got this study off the ground and analysed and spent hours hooking people up to all the psychophysiological equipment in the brain scanner. So let me pause and let's see if there are any questions.
Great, Jessica. That was a great presentation. Thank you so much. I see that there are quite a number of comments and questions in the chat. So I'm gonna start with the chat, and then after that, please raise your virtual hands if you have any comments or questions. I'm gonna start with Jeff Boris. You left the comments there. Do you want to start?
Yeah, that's interesting that you're seeing 90% of patients, or actually nearly 100% of patients having joint hypermobility. In my pediatric clinic, it's along the lines of 75%, and that's any kind of hypermobility. You know, a Brighton score greater than or equal to 1. Yes. So, and we had previously reported at least 61% in patients having any kind of hypermobility, i.e. HEDS or HSD, and published that. But the other comment that I have at the end is, you know, you're in your conclusion, your first statement was that brain fog is overlooked. I would not necessarily agree that it's overlooked.
I think it was when we put in the grant in 2017 or 18, which was a long time ago, and I think that may well be different. It's certainly in terms of the press in the UK, brain fog is huge. There was a whole Men's Health thing about brain fog, which is, you know, pretty impressive.
Yeah, I mean, certainly having been caring for POTS patients for 23 years now, and specifically seeing pediatric patients, I find that the brain fog is absolutely a problem for patients being able to function in school. And so it is very much up front, even before 2017. And you know, I think for the, and I know Peter has also seen obviously a fair number of pediatric patients with this too. So yeah, I mean, I think it's fascinating that with the lower body negative pressure, you were able to do this study. Amanda Miller had a study similar a few years ago where she didn't look at hypermobility, but demonstrated that, and they didn't use lower body negative pressure. They just used actually orthostasis. They had the patients upright, and they did specific testing for cognitive function and found that upright position in POTS patients also reduced cognitive function, or therefore caused brain fog.
No, I mean, I think it's it's one of these things like certainly when I was at medical school and I graduated from medical school in 2006, I was taught that the brain, auto-regulated, the blood-brain barrier was fixed. Not that necessarily the blood-brain barrier is important to this, but that, the cerebral perfusion was constant. And it makes an awful lot of sense that if you've got purple feet from standing up, that maybe some of that blood isn't in your head anymore.
Absolutely.
And I think it's also hugely validating for this group of patients who are often, I mean, I'm sure you're all wonderful POTS doctors, but it's often not well appreciated by the mainstream, well, mainstream is the wrong word, but most medical professionals. And these people are often told, that there's absolutely nothing wrong with them. And so to see that there are characteristic blood flow changes is very interesting.
The next comment is coming from Stellana. Do you wanna?
Hi, Jessica. Thanks for excellent presentation. It was nice seeing you in Toronto a few weeks ago, even though we briefly bumped in. So
Yes,
that
exactly.
was good. So, I was there teaching a course on neurologic manifestations of EDS, like the entire day it went by. And so there I did manage to sneak in this new study by Peter Novak showing that in his autonomic lab, and he does great testing, including cerebral hypoperfusion, 90% of hypermobile EDS patients, the diagnosis was made by geneticists at Mass General, showed some kind of autonomic impairment. He calls it mild, sure, but nevertheless, autonomic dysregulation was objectively confirmed. So that's very important, and I emphasize that on my slides. But I think the second thing, which I think equally is important, is how we frame the whole anxiety issue when we talk about POTS, including autonomic dysfunction in EDS patients. Because as you mentioned later, a lot of these anxiety scores have certainly, hyperadrenergic symptomatology written in. And so how do you separate anxiety over here from anxious thought process from physical anxiety, which is, I call it a clinical feature like hyperthyroidism or, high blood pressure, pheochromocytoma, and dysautonomia. I think we have to be very careful because when you say autonomic interoception and miscalculation, I honestly, I have to cringe on that because the problem, I think, is that a lot of these regulation of organs and how organs function, blood pressure, heart rate, barrier reflexes, respiratory control, they're at the brainstem level. And you can't regulate your brainstem. That is set. You can only react to how the brainstem is working. So if you want to measure cortical reactions, that is a different story entirely. But I think that's where I diverge from my colleagues, in the F&Z world that say, well, the brain is not processing the information that comes in. And I say, well, I don't think so, because the cortical processing is one thing, but the regulation of all autonomic vagal nuclei, vestibular nuclei, everything is in the brainstem, and you don't control your brainstem, even when you want to. How do we know? Well, when you have a stroke at the brainstem level, you end up with labile blood pressure. When you have a stroke in the right limbic area, you can have the same. So subcortical structures, you can't, control that. So my comment when you do these research studies, I think they're very important, but I really don't want them to be weaponized by people who say, oh, you're anxious, if you just get control of your autonomic nervous system. That's not the case at all. Now, it is the case with panic disorder, generalized anxiety, PTSD. That is very different than POTS. That is very different than post-COVID, dysautonomia. So I talk about these issues commonly because I don't want them to be lumped together. And I tell neurologists, use your beta blocker, use your midodrine, and then talk about, you know, how your brain can, you know, improve. And some people are very anxious. That's absolutely correct. Okay, that's my comment out there.
I love it. Yeah, no, and to be honest, Svetlana, I think we are probably talking from the same, actually from the same page, even though it might not seem like it. I don't think that POTS is anxiety. I think all anxiety, well, anxiety and is that the features are features of autonomic problems. They are sympathetic activity. That is, and we call it anxiety when it's associated with what we think of as, you know, abnormal cognitions or what have you. But there is no sort of uh, there is no, I mean, phenomenologically, they are the same, the feeling of your heart racing and all of that. And I think that a lot of people who get an anxiety label probably have underlying autonomic dysfunction, and that the presence of exaggerated sympathetic responses may cause uncertainty, particularly if you don't know that you've got postural tachycardia syndrome and you are feeling as though your physiology is all over the place. That could condition you to feel anxious. So I often, when I'm talking to patients in clinic, it's like, I thought I was anxious, but actually I was just hot and my clothes are too tight. This is a thing, you know, with obviously with neurodivergent people. We assume and we're conditioned to be told that we're anxious because we feel weird. But if you know why you're feeling weird because you've had a large meal, you've had a hot shower, or you've just gone from standing, that makes a huge difference to your framing of those weird sensations. So you're right, probably the term perceptual mismatch isn't great, and we can, with that paper is we've pre-printed but we haven't finalized.
Don't put me as a reviewer.
No, but I personally, I don't even believe in the idea of functional neurological disorder. I mean, I don't, but I can see how you're right about the weaponization. But these patients, and we showed that the orthostatic challenge didn't seem to induce anxiety. But yeah, anxiety is a really messy mixed thing, and so, like the Beck anxiety inventory is almost all autonomic. The SDAI is almost all not autonomic. The DSM criteria are all not autonomic. So it is really difficult. But I think patients who have autonomic dysfunction, they may get mislabeled with anxiety, and because of their exaggerated autonomic responses, they may be more likely to experience anxiety, say in the case of panic disorder. But understanding that this is physiological and not inherently psychological is really important.
Yeah, I think
that takes me back to the first slide, which is it's awful that patients have been subject to this sort of weaponization, but this is part of the problem of it being siloed between physical and mental health. People are having an experience, and the experience is weirdness, and the weirdness is caused by a brain-body interaction. And but whether you call that, and understanding that brain-body interaction means actually, yes, I should use beta blockers, I should use POTS drugs, I should use electrolytes, I should use compression. And that's what I want, is for the patients to have targeted interventions that specifically will reduce their symptoms, whatever we call them, but they're phenomenologically being weird.
Yeah, I completely agree with you. I will just point out briefly that when you ask patients, you know, were you anxious? And they say, no, I was just sitting watching TV and my heart rate went up. But there are patients who say, I have a patient with severe agoraphobia, and she's like, I'm afraid to come out. That is very different. Whatever thought triggers, to me, as a neurologist, if you have a thought pattern that triggers anxious thoughts and therefore activates autonomic symptom, that is generalized anxiety disorder. And most people with generalized anxiety disorder have totally normal tilt table test. But when when it's
that's what we showed in those slides.
exactly.
It's a
exactly.
non-hypermobile anxious people had no change in heart rates, but
Right.
the hypermobile anxious people, that was GAD under DSM criteria.
Yeah.
Yeah. I mean, I think, but we also know, because we see a lot of POTS and hypermobility in our neurodivergent brain body clinic, that a lot of our patients, obviously it's neurodivergence, they're autistic and they have ADHD, and they have something almost characteristic, is something called alexithymia, which is a difficulty recognizing and explaining emotions. And so people can often, so the patron of the charity that I am chair of, Jane, she's autistic, and I tried to talk to her about the hypermobility anxiety link, and she's like, I don't know what anxiety is, but I know I'm often discombobulated. And the thing is we all have different languages and things, and some of us just know that we're not right or that we feel weird, but wouldn't necessarily call it anxiety.
Okay, we still have a lot of comments and questions, so I'm gonna just skip to just a few of them. Actually, I'm gonna just skip to Dave, Dr. Goldstein. You're on mute now.
Thanks for the interesting presentation. I have a simple question. Is there an excessive fall in venous return to the heart during LBNP in your hypermobile POTS patients?
Well, I have to say, I don't think I've looked at we haven't looked at the physiology that we acquired in the brain scanner. That's part of the next tranche of analysis. So it's a really good question, but I don't have the answer. We have the data. We've got all the data, but we haven't.
What did you measure?
We measured heart rate. Both.
No, I mean, what did you measure in terms of the extent of change in venous return to the heart?
Oh, well, we didn't do any we just did heart rate and respiration. We didn't do any like Dopplers or we tried, and we really tried, and Professor Matthias may remember this with Hugo, we really tried to do beat to beat blood pressure in the scanner, but there were being able to do it in a 1.5 Tesla scanner, but for some reason in the 3 Tesla with the ASL sequences we couldn't do it. We did.
Well, that wouldn't be a measure of venous return to the heart anyway. What I'm trying to get at is it's tough, and all relatively easy physiological measures are so indirect that they don't really address they don't really provide a measure of that key parameter. And so I think it's really important to come up with a way to look at the venous return to the heart. David Streeton did this, I don't know, 40 years ago, using a sort of a radio tracer kind of approach rather than Doppler ultrasound or something like that. So it may require a return to that kind of approach. But if you haven't looked at his work on mechanism of POTS and the excessive orthostatic venous pooling, you really should.
Thank you.
Okay, with the interest of time, I'm going to skip to Dr. Chris Matthias first.
Well, that's very kind. And Jessica, firstly, congratulations. And I hadn't realized the field had expanded so much, and you brought out so many aspects, bringing together different disciplines. When Hugo joined us at the end of the last millennium, it was to look at fMRI in various autonomic disorders and so on. And POTS hardly raised its head at the time. And then, of course, HDS, and it's amazing how things have galloped on, I quickly add, with a lot of questions. I've got one little question, which is, what is the role of conditioning in terms of this? So, for instance, if I walk out and I'm putting myself now as the model, as it were, go out into the garden, I find it helpful because I love plants and flowers and the rest of it. I'm just looking at the reverse. Could it be that conditioning actually accounts for the, and I know there was a lot of time spent on anxiety, possibly even on brain fog, which is a key feature in some of these patients when they change position.
So do you mean, sorry, do you mean conditioning in terms of like Pavlovian conditioning, or do you mean deconditioning, or do you mean context? So if you're in a...
Thank you very much. Pavlovian is really what I was after, because of course, if that is the case, then there could be a role for deconditioning. I have no idea how you do it, of course, but you're quite right. It is Pavlovian. I should have mentioned that. The word.
So, yeah, no, absolutely. So that's one of the real problems and the limitations of the study that we did, is that when you apply the lower body negative pressure in the brain scanner, your whole body moves, and the pressure device is very, very noisy. So the idea, we can't really easily make it a sham so that people think they could be having lower body negative pressure applied when they're not, or we haven't worked out how to do that. I'd be interested to hear if other people have, but I think that, and it sort of takes us back to what Svetlana was saying, and there's been some, discussion in the chat about this distinction between anxiety and autonomic dysfunction. Is Hugo, who's my PhD supervisor, did some really interesting false physiological work in the brain scanner, where they showed that if you played in someone's ears what they thought was their heartbeat, but it wasn't actually, it was either their actual heartbeat or it was a higher heartbeat, even neutral images with a higher heartbeat were rated as more intense. So the autonomic nervous system is a context setter for the interpretation of emotion, whether that's pathological or not. But essentially, if you have a uncertain or ambivalent feeling in the context of a high heart rate, you're probably going to feel it more intensely. And so to that degree, your physiology is shaping your emotional milieu.
Thank you. Thank you very much.
Well, first I'm gonna last comments in the chat section. Peter Rowe, Dr. Rowe.
Sorry, I just wanted to respond to David's question that Linda Van Kampen had done a study where they had the extracranial blood flow, extracranial Doppler measurement of cerebral blood flow. And the people who were tilted upright with hypermobility had about a 30-some% reduction in brain blood flow, which is usually about 6 or 7% in healthy people. And she compared the hypermobile ME/CFS patients to the ones who didn't have hypermobility. They still had reductions in brain blood flow of about low 20% range. But that paper is at least partially answering the question. We think that that reduction in brain blood flow is entirely related to the reduction in blood flow return to the heart, venous return.
Yeah, thanks. It seems to me that if the patient's in the MRI, you should be able to come up with some way to evaluate the size of veins.
Well, if only we didn't have the coil just on the head. If you could look at.
Oh, it's a. Sorry, I thought it was an MRI chamber.
Well, you need a coil on a particular part of the body. We can't do so the the MRI images were coming from the head. We can't simultaneously capture both the MRI and the heart. So that would be really interesting. We were looking into getting a MR compatible Doppler,
Right.
which would be really exciting. But we didn't have
Yes, because
that
you
money.
can look at the inferior vena cava as it comes up to the heart, and it does change in pretty substantially in its volume. So you should be able to get numbers if you're able to do that.
Yeah, I think one of the problems is, well, obviously, this was funded by Dysautonomia International. They're very generous, but we're not talking huge amounts of money. And this type of equipment in the MRI environment is difficult and problematic, and that would have been ideal. We did when we wanted to do this project, we also wanted to simultaneously do FNIRS, so infrared spectroscopy, to look at the blood flow whilst we were doing MRI. But the MRI compatible FNIRS machine, there were some problems, and it would basically it's just been so, it sounds silly, but technologically fraught, that we plowed ahead with just the imaging. If we had been able to get the porta press working in the brain scanner, we could have got proxies of cardiac output and total peripheral resistance from the autonomic software, from the beat to beat blood pressure measurements, but we were unable to get that to work in the 3 Tesla.
Yeah.
Jessica, do you have a few more minutes to answer some
yes,
questions
of course.
from the audience?
Yeah.
Oh, Alan, do you want to go first? Thank you so much.
Oh, sure. Thanks. I just put my comment in the chat. I think it's very important that we consider the interaction of all the various symptoms in these syndromes. So years ago, when I gave my first talk on mistaking autonomic symptoms for psychiatric symptoms, I had parents come up to me afterwards and say things like, once we got my son's sleep problems under control, he didn't have ADD anymore. And once we got my daughter's pain under control, she didn't have anxiety anymore.
Oh, no, I'm absolutely sure. Yeah.
So it's really hard it makes it complicated to measure autonomic function when somebody's autonomic test results today are going to depend on hydration status, going to depend on their pain level, going to depend on how well or poorly they slept the night before. I think that's hard to control for in any study, but clinically it's really important.
Oh, yeah, no, absolutely. And we need to look at the whole person. But I think we sometimes as I said, I am a psychiatrist who is generally tending to try and explain medically unexplained from a a medical explanation. But there is this two-way interaction, and we need to be mindful of both. But the really important thing is to try and understand the underlying brain-body interaction so that you can target the treatment. And just as you say, if you sort out someone's sleep, maybe they won't have ADHD or and yeah, it's just trying to, I think we're trying to write a paper about it called The Perfect Storm, which is basically there are so many intersecting factors. And if you can improve something like autonomic dysfunction through relatively simple solutions like beta blockers or electrolytes or compression, you could actually make a huge difference to someone. You're not necessarily going to change everything, but in the post-COVID and in brain fog, in menopause, in all sorts of things, it would just make a huge difference. But understanding, and I think the key point of this is not to get in a kind of psychiatrist, not psychiatrist divide, is that the number of connective tissue features in hypermobility is particularly associated with brain fog induction, and that we should be checking out all of our patients for hypermobility.
Great. Gordon, do you have a question or comments?
Yes, thanks. I was wondering, I'm not a physician, I'm a research scientist with POTS. With regards to the outcome you noticed with increased brain fog with tachycardia. How stable is that as far as like the population cohort? Do you still do people that don't respond, are they the same over time? And what, I don't know the mechanism for this. So I have baseline brain fog, right? But when you get presyncope and you get sort of neurological malaise, are those actually the same process? Like, what's the evidence for that? Like, could it just be like a similar phenotypic outcome leading to the, more malaise? I don't know. Like, what are your thoughts on that?
Well, I think you're basically in a vulnerable state, which is going to be exacerbated in a subgroup of people by orthostatic stress. And what this study suggests that is people who have connective tissue features in hypermobility are particularly vulnerable to brain fog induced by orthostatic stress. How we measured brain fog was very simple in that we measured brain fog through a visual analog scale. We did, whilst we were doing that, we were taking physiology measures, but we're going to put them all together when we do the brain imaging analysis. This was really, this analysis is all about trying to see how, if we can predict who is more likely to experience brain fog as a consequence of orthostatic challenge. And that looks like if you have symptomatic hypermobility and lots of connective tissue features, you are more vulnerable to brain fog as a consequence of that challenge.
So Jessica, actually, can I ask you a last question? I know it's pretty late there. So what is a DEB treatment? I know you briefly mentioned that, but didn't really tell much about it. If you can just briefly tell us just rationale and how do you approach those patients? What is a DEB treatment?
Okay, so ADAPT was so we have done this work about this idea of interoception, which is the inner sense of what's happening in your body. And some people, so in a group of people, this was autistic people, we showed, well, I didn't show, our group showed that there is a mismatch between, and Svetlana might not like the word mismatch, but there is a discrepancy between people's inner sensations of what is happening in their body and their ability to accurately detect them as per cardiac interoceptive tasks. Cardiac interoceptive tasks are quite controversial in the interoception field. Some people think that you'll just assume that your heart is beating like every second and you might not actually be really understanding your heart. But so what it seemed is if you normalize in space someone's accuracy at detecting their heart rate and their sensibility to their internal bodily sensations, the greater that discrepancy, the greater the anxiety. So what my colleagues Hugo and Lisa and Sarah showed was that if you undertake interoceptive training, so you have a pulse oximeter or similar, and you do something to increase your exercise, like well, going up and down stairs or jumping jacks, and then you get feedback on your heart rate. It's a kind of, we call it an interoceptive training program, that improving your interoceptive accuracy reduces anxiety symptoms. So the ADAPT study took interoceptive training, and it also took, and this is perhaps controversial, it took principles from cognitive behavioral therapy, where you basically reduce people's worry about their internal bodily sensations. So you're improving the accuracy and reducing the worry with the goal of reducing anxiety, which we did, and we're in the process of trying to get that published. The interesting thing was the control experiment worked just as well. So it basically showed that if you had a therapist who understood about things like hypermobility and POTS, you felt well understood. But in the interoceptive, in the ADAPT group, the change in anxiety was related to a change in interoceptive awareness, Whereas in the control, which was emotion-focused supportive counselling, the change in anxiety was related to the rapport with the therapist.
Oh,
They both reduced anxiety, but by different mechanisms.
would it be fair to say similar to biofeedback program?
Yeah, it's a bit like a biofeedback program. Yeah, yeah.
Mm.
But I think
Okay.
the thing is, the interesting thing is we're rolling this out at the moment using ECGs and tablets. So the problem with pulse oximeters, as some of you will be aware of, is that if you have, which we discovered during the ADAPT study in a big way, is that if you're hypermobile, you probably have Raynaud's, and Raynaud's makes getting a good signal off a pulse oximeter to be able to provide feedback really difficult. And the other thing that that COVID told us was that if you have darker skin, pulse oximetry is not reliable. And so we are trialing at the moment a tablet with a kind of ECG band so that you can get feedback that way. But the next thing that we're going to do, we put in a grant for a different iteration, which is something called plethysmography, which is if you hold your phone, the micro vibrations picked up by the actigraphy can potentially tell you about changes in heart rate, which are not light sensitive, because the problem with the pulse oximetry is that it's light sensitive.
Right. It's really fascinating. Yeah, I would like to see the publication for that. I know it's pretty late there. Past 6 is dinner time, so I'm
It's fine. We don't need dinner yet, but if you if anyone has any questions, I'm happy to answer them. But it's been really lovely to be able to talk to you, and so fantastic to get your comments. But I think there's such a need for more research in this area, but I suppose my underlying passion really is to make everyone think about hypermobility all of the time.
Yeah. Thank you so much for the fantastic talk and all the discussion. After checking with the media office, we'll likely post this video in the Hopkins YouTube channel. So just pay attention to my email. We'll send the link when it's uploaded. Again, thank you so much, Jessica, for your great presentation. Everybody for this discussion. Have a good rest of the day.
Yeah.
See you guys.
Bye.